after a very exciting morning session, we assembled again for the afternoon session, and I realized that after lunch it's difficult to be awake. But we thought we'd keep a panel discussion so that at least you can't doze off. People will keep looking at you, and there are 5 of us looking at you. So the topic that was decided was to talk about rituximab, because this is the flavor of the disease, and it's been there for about 25 years now. But it has been in nephrology also for a long period of time. But it's been evolving, its indications are evolving, and also its use. Indications are becoming much clearer, but the dosing and how to use it best. So we have experts with us who have been they have a deep knowledge about the science behind it, and also they have used it extensively. So it's a time for us to pin them and ask them as to how they best use it in their practices. So initially what I'll do is I'll give a brief overview of the pharmacology and then deep dive into the questions for you. So a brief review of the B-cell biology, pharmacology of CD20 antibodies, and then we'll move to the final discussion. So but the B-cell biology, as you all understand, that the B-cells develop first in the bone marrow, and then subsequently they migrate to secondary lymphoid organs, such as spleen or lymph nodes, and then finally they also form niches, the plasma cells in the bone marrow again. And during their journey and during their evolution, they acquire different markers, and these markers are both for the development of the cell for the purpose of the B-cell, and also for us to target them at different stages before that. So as you can see, the CD19 is present all throughout the plasmablast, and CD20, which is the marker of our interest, is usually there in the pre-B cell and maybe in the early plasmablast, but not in the late plasmablast and plasma cells. The only thing to understand from this is that for our purposes, when we do anti-CD22 therapy, we want a CD19. And often the post will ask a question, why do you want a CD19? We are doing a CD20 antibodies. So it could happen, two things can happen, that when you use an anti-CD20 antibody, it might cover the cell, but it might not kill it. But if you really get a CD19 low, that means the cell is really not there, it is just not covered, it is really dead, or not at least in the peripheral circulation. That's why when we use anti-CD20 antibodies, we do the CD19 test. And as you can see below, which also there's the BAF and the TAS, which was discussed extensively in the morning talks, they are become useful as the cell progresses at different stages, and therefore blocking them also has specific effects on specific cell levels. Now, what are the therapies which are normally used to modulate the B cell? So, the left end of the panel, you can see here that you have the B cell depleting therapies, and largely we have the rituximab, ocrelizumab, obinutuzumab, and afatumumab, which was briefly discussed, and we'll discuss a bit more about it. And we have the CD38, that is the daratumumab and felzartumab. Also CD19, we have the enifilizumab, but currently the flavor is anti-CAR T cell CD19 therapy. To block the markers, we have the belimumab, which blocks the BAF, and we have the APRI blockers, which we discussed in the morning, atacicept and telitacicept, and also we have CD22, which is blocked by aprocazumab, and APRI is also blocked by several. Like that, we have a number of drugs which can either modulate the B cell function or can kill the B cells. Now, when we deplete the B cell, what really happens? So, in the periphery, when you deplete the B cells are not only just a bystander cells producing antibodies, but they produce a number of cytokines. And these number of cytokines can affect also the T cells, affect also the other cells, and also in the inflammation, and also in the autoimmunity, and also in the defense of the body. So, they produce a lot of cytokines, which are like the GM-CSF, IL-10, the TNF alphas, and all. And once you deplete them, these levels may go down, and the IL-10, which is supposed to have a more salutary effect, that is the development of T regulatory cells, all may come up. In the niche, that is in the bone marrow and the gut, what happens is that you do deplete them, but again, when you deplete any cell, the body tries to recompensate for that, and there will be increase in the amount of BAF or TACI which becomes available. And that's the reason which you will see later on in the discussion probably, that why in certain disorders the B cell therapies work well, and certain disorders, despite seemingly having a good role in the pathogenesis, but they don't seem to be working. And the third category is where the tissue, what happens is that in the tissue we do get a depletion, but it's quite variable. As was discussed in the morning, the depth of depletion may be depending upon the type of antibody that you use, whether they are really able to deplete what is there in the tissues or not. And that might again decide which diseases these therapies may work well or not. So these are the use. We should understand that when you use anti-B cell therapy, it is not just the periphery, but also what happens in the niche and also what happens in the tissue becomes important. So what is CD20 molecule? CD20 molecule has got two loops, and the antibodies which are the rituximab, which is the first antibody developed to CD20 antibody, was a 451 amino acid. It's a light chain which is the chimeric antibody, so that the mouse variable region, and otherwise the constant region is the human region. What is the function of CD20 is not very clear, but it is something to do with cell signaling and the calcium in the cell, but it's not very clear why CD20 actually exists in the body. It's not very clear still. What is the mechanism of action of the anti-CD20 antibody, the rituximab? So we've got four mechanisms how it can kill the B cell. Either it can have antibody-dependent cellular cytotoxicity, so that it invites the cells, which like the NK cells, which can kill the cell by bombarding them, or it can cause direct cross-links with the rituximab, and the B cells can directly die because of it. It can activate the complement, and complement activation can also kill the cell. And the fourth mechanism is that when it coats the B cell, it can be engulfed by the macrophage. So these are four methods by which the B cells can be depleted by using the anti-CD20 antibodies. Now, as we discussed in the morning, that there are other molecules which have come up, and what is the difference between one or the other? So there are something known as a type 1 anti-CD20 antibody and type 2 anti-CD2 antibodies. And the type 1, what it does is that if you see the left lower panel over here, you see that all this, when you use the type 1 antibody, it brings all of these the CD20 molecules into a lipid raft and then attacks them over there. Whereas in type 2, they don't bring them to the lipid raft. The difference between these two is that what you can see here is that obinutuzumab is a type 2 antibody, which actually has a lot of direct killing which happens with it. That is, which when it brings them, which does not bring them to lipid raft, they are not protected, and therefore you get a lot of killing with it. Whereas in type 1, you don't get so much of a direct killing, but you get a lot of CDC killing and also some antibody-dependent phagocytosis. Similarly, with ofatumumab, it is more humanized, but it also does not work directly. Difference here is that ofatumumab acts on the two sides, both also the small turn, also the big turn, and therefore it binds to different epitopes compared to rituximab, which only binds to the single large turn of the CD20 molecule. And therefore, ofatumumab probably is more humanized, binds to a larger area, and might have a much deeper effect. But obinutuzumab is supposed to have a direct killing, and sometimes where these two do not work, obinutuzumab may work better. And this is because there is some change in the sugar molecule of this antibody, which has some bioengineering done, so defucosylated in the antibody preparation. So this is some of the science behind what are the differences or salient differences between one type of antibody versus the other. Now, where does it work best is that if you see along that thing, rituximab sensitive, some diseases are very, very residual sensitive. So all those disorders where they have antibodies which are usually in the circulation, they tend to do much better there when you use rituximab. And they are partially sensitive when there is a mixture of things, that they are in the circulation, also in the tissue. And when they are more limited to the tissues, or when there are very multiple number of antibodies, and some of them which are a lot of memory antibodies are there it may not work well. As you have seen that the anti-CD20 antibodies are not there in the memory cells, and therefore they may not be working on those disorders. So these are just general overview of how it works. So long-lived plasma cells are not affected by this anti-CD20, and therefore even we find that with patients who are vaccinated in the past for tetanus or something, they still continue to produce those antibodies, and their childhood vaccinations are not affected when you use a current therapy of anti-CD20 antibodies. So dosing of the rituximab, now the dosing, this is where we need to have a lot of discussion in which disorders, how to dose and how to go about monitoring them. So in general, if you get this slide just tells you that there are numerous doses which are available. Some doses were derived from the lymphoma therapy from where it was first used, and then we came down to either 375 once a week for 4 weeks, or 375 in a monthly doses, or 1 gram dose, which is the glomerular disease dose, or a single dose or multiple doses, and different disorders. So to begin with, I would ask Aditi, because she's been expert in the Podocytopathy in the morning, she did talk about rituximab. The question really is that when do you actually introduce rituximab? In the steroid sensitive, you did mention that you use it, and you said you use it with patients who are frequently relapsing or who are dependent. Now, frequent relapsing, they said they have 3 episodes, at the end of 1 year, we get 3 episodes. So, a total of 3 episodes in a child. Would you introduce rituximab, or you still go with a low dose steroid? How do you do that?
Yeah, so thank you. I had shared with you the algorithm of the Indian Society of Pediatric Nephrology, in which rituximab actually comes at the very end. So we would start with the milder agents, which are with fewer toxicities and can be used more safely with less monitoring first. If that works out, well and good. If it doesn't, then you move to the next and move to the next. This is a long-standing disease. It's not going to go away with one hit with a potent agent. And young kids are at higher risk of hypogammaglobulinemia, etc. complications. They are also building antibodies to various infections. So we would want to avoid their usage in young children. So in our algorithm, it will come in the most refractory cases, which we call difficult to treat steroid-sensitive nephrotic syndrome, which has failed at least 2 lines of therapy. At least one should be like MMF or cyclophosphamide, and very often even after CNI.
So you put CNI.
But I mean, CNI and rituximab we actually use interchangeably in good centers where you can monitor them well. But for the guideline purposes, we have kept it beyond CNI.
So, question: what dose do you normally use in children?
Yeah, so initially with the first time when we had published in 2007, 5 patients steroid-resistant nephrotic syndrome, we had gone with the lymphoma protocol of 4 doses, 375 mg per meter square, given a week apart. Subsequently, we have chosen to use 2 doses, 1 week apart, looking at CD19. If it's depleted, we do not give any more doses. And if it's not depleted, we give another dose, look at CD19 again, up to a maximum of 4 doses.
So when do you do your CD19?
About a week later, 5 to 7 days later.
And you would keep it below 5 or 10%?
Yeah, so less than 0.5% or 1% and less than 5 cells, but we also accept up to 8 cells, 10 cells, up to 10 cells, not more than that.
And once you have dosed it and the patient is okay, and you wait for 3 months, 6 months, then you redose them, or you wait till the relapse happens, or you wait till your CD19 comes.
So in nephrotic syndrome, since these patients are the most difficult ones who have been difficult to manage, usually they have anthropometry, short stature, steroid toxicities. We want to avoid steroid usage and other medication use. That's why we gave it. So after 2 doses in steroid-sensitive nephrotic syndrome, our own experience shows that the median time to next relapse in sensitive disease would be about 17 months. So we choose to dose them annually if we have to give them sequentially, while ensuring that B-cell repopulation has occurred, as well as that the IgG is intact and there's no chronic infection or repeated infections happening.
You test them for the levels of IgG at some point, or you just...
Yeah, so we would, when they come for their visits, we would test them. So at least 2 times before we plan the next dose. And so in sensitive disease, we would be dosing them annually if we use sequential dosing. And in the steroid resistance, the median time to next relapse we had demonstrated was about 8 months. So therein we elect to use it 6 monthly, provided the B cells are back. So if at 4 to 5 months B cells are not back, we look at it again in 6 to 8 weeks. Again, if it's back, then we give another dose. But again, there has to be some kind of a sense of how long do you give. So we do not go beyond 3 years or so with any kind of policy. So generally, sensitive kids would receive fewer doses.
And would you use, I'm doing a lot of rapid fire questioning now. Would you use rituximab alone or with steroids or no?
So the whole idea of using rituximab is to get off all other medications. So in our unit, we would take off everything else. And some units would be using a single dose followed by MMF. Like in Japan and Singapore, they would be following this policy that you follow it through with MMF. We tried that follow through, and we also have international survey data which indicates that if you give 2 doses, whether you give maintenance immunosuppression afterwards or not does not matter. But if you are using a single dose, you would probably need to use maintenance immunosuppression to get good effect. So we use 2 doses and nothing else up. We taper off everything. So MMF stops the day you have dosed. If you are on a CNI, you taper it in the next 2 months and get it off. Steroids also we taper off in the next 2 months and they are off. So.
And do you use prophylaxis of Septran in your podocytopathy?
So in the initial patients, again, when we started using, we did use Septran. We would recommend to use Septran if for any reason the child requires combination immunosuppression. So very often we have young children with steroid-resistant nephrotic syndrome, disease starting out at 2 to 5 years, and you have CNI vintage of 3 years, child is continuing to show relapses. You know that if you were to take off the CNI, it won't work out. And very often you end up using sometimes returning to CNI also afterwards after you have given rituximab. So if you're going to use a combination like Ritux plus MMF or Ritux plus CNI, then please do use a prophylactic agent, and usually that will be Septran that you use.
Thank you. So she has really cleared out. If you have any questions on how to use rituximab in children with steroid sensitive or steroid resistant, if you have any questions, you can ask. So I'll now move to.
Sir, I have one question. Ma'am, actually using rituximab in children interferes with their vaccination schedules at times. So how do you deal with this?
It actually doesn't, because nephrotic syndrome generally starts out around 2-ish, 1 year plus. By that time, most of your vaccines are done by 2 years. Certainly not using rituximab around that time. You're probably going to use rituximab almost never below 5 years of age. Almost never in any of the situations even I described. So it's going to be usually between 8 years onwards that you're using. At that time, not many vaccinations are not interrupted. But yes, the vaccine responses might have kind of become weak over a period of time. So when we have looked at in that context tetanus and hepatitis B responses, we did find that the protective titers had waned for hepatitis B, and it does take more doses to get it back up. So if you are on sequential rituximab, for tetanus it was not such a big issue, but for hepatitis B, yes, it was an issue. So double doses and multiple doses were required. So you need to monitor anti-HBs antibody titer also. We do that routinely in our unit for rituximab patients.
Ma'am, what should be the gap after giving rituximab if the child has missed the vaccination? There are few kids who don't take the vaccination in their proper schedule. What should be the time gap to give a live attenuated vaccine? What you were talking was killed vaccines or adsorbed vaccines, but what should be the time gap for the live attenuated vaccines?
So there's not a very great idea that we would have. Certainly the B cells have to be back. CD19 cells have to be back. Live vaccines you would be careful using in patients who are on rituximab or have been on rituximab. Almost very few vaccines are live vaccines. So you have varicella, you have measles, and what else do you have? Polio is already gone. It's in the first 5 years anyways. You've given all your doses. So the chief issue is around varicella actually, and we don't do varicella vaccination during those years. We don't. What happens? It is better that you would have given it before. If you haven't managed to, then you have to be around the exposure time. You'll have to be worrying about using acyclovir starting day 8 of exposure, etc.
And do you recommend pneumococcal vaccine beyond 5 years?
Yes, we do. So there are recommendations again in our guidelines about how to use pneumococcal vaccination. So if number of doses received versus now not received, and we have guidelines on using PCV first followed by PPSV 23. Total lifetime doses of PPSV 23 is 2. Don't exceed that.
And actually, I'll ask what about the adult in the same situation? If we have when do you actually use rituximab in either a minimal change or an FSGS? First minimal change and then.
Yeah, generally here in our center, that's not the first line of therapy. First line is always steroid, and then even if it's steroid resistant, we go on to either cyclophosphamide or we go on to CNIs. So it becomes like the third or the fourth option that we have, unless you have conditions where you cannot give steroids. Like you have an obese patient, you have a diabetic patient, you already have steroid toxicities, which will come in this person, a person with recurrent infections. Then we'll think of using steroid-sparing agents. Which one of them will be rituximab?
And the dosing thing, would you use?
Dosing thing is usually 1000 milligram once in 2 weeks.
Same like membranous mentor. So most people nowadays are glomerulonephritis more using a larger.
It's more convenient.
And probably you are ensuring that your CD19s are really down. But in a patient where there is a minimal change in your steroid sensitive, where you think that the proteinuria may not be non-specific and maybe a selective proteinuria, would a lower dose be okay, or do you think?
Maybe a lower dose, but in those cases we generally don't give rituximab. In subnephrotic cases, we just manage.
No, not subnephrotic. Patients like minimal change responding to steroids, they are not becoming steroid dependent. Every time they keep coming again and again. And you want to then
for repeat doses. Yes. For repeat doses, then probably not the full dose of 1000 milligram into 2 doses, maybe a 1 dose of 1000 milligram. And anyway, you'll be checking your B cell profile and immunoglobulin before you give the rituximab.
Any alternative thoughts on it?
While we give rituximab, we go in slightly. In our unit, we use rituximab as a first line agent to spare steroids. Like after, obviously, if somebody is steroid dependent or frequent relapsing, because the ease with which and the economics that comes with rituximab. So we give one dose of 375 milligram per meter squared. That is when the patient is in remission. So unlike membranous, you are not worried about the rituximab going down the urine. So we just give one shot, 375 milligram per meter squared. Then we monitor CD19 at the 6th week and at the in between 3rd and 4th week. And if there is reconstitution, which happens in most of the cases, they receive the biosimilars. So it happens in most of the cases. We again give 100 to 375 milligram per meter square, depending upon what is the count. If it is like 50 plus, then we give 375 milligram per meter square. If it is like 10 and 11 cells per, then we just give 100. That's been largely all.
Questions?
And I just wanted to add to that. There's a paper I was talking to you about it. Dr. Jacob George published from Trivandrum, in which he used 100 milligram rituximab in primary podocytopathies, and he demonstrated short-term and long-term good effects. About a small series of 30 patients, all with primary podocytopathy, either MCD or FSGs. So actually, we also are using rituximab as the first second line agent. If they are steroid sensitive and they respond, then the next time they have a relapse, we give steroids, get them to remission, and cure rituximab. And what I've been doing recently is that we are monitoring them long term. So if they relapse, then we give rituximab alone, or we preempt that. So suppose they relapse within 12 months, then we give it 11 months rituximab. So that makes sure. Just the reconstitution alone does not predict relapse. Some patients do have but they don't relapse at all. And some patients remain relapse free for a long time, even after one dose of rituximab. So single dose rituximab is what we're using, and I am now starting to use the 100 milligram regimen. Let us see how that works out in the long term.
I mean, whatever you do, there should be a protocol that the unit follows, because everybody would do their own thing and then you wouldn't know what worked and what didn't. One. Second thing is that patients are also different categories. So if you start out in a mild patient, a small dose might work out, whereas a typically difficult patient would not do well on that small dose. And when we are dealing with the really difficult ones, we find that 375 mg/m² is also resulting in like a steroid-resistant nephrotic syndrome, CNI dependent, relapsing on CNI multiple times. You're using 375 doses and you need to give them again at 6 months. I don't think 100 mg would have worked out at all. And while there is one paper and maybe there's another one paper on such a dosing, I think we need good quality data, including pharmacokinetics as well as B-cell subpopulations to figure out whether it works out or not.
So I think
absolutely agree with all that. The only thing what we do is after giving 100 milligram, within 2 weeks I check whether the E-cell has come below 1%. If it hasn't come below 1%, I give one more dose. I don't. First time I just make sure that they become B-cell negative before concluding. And that actually works, because suppose they need 500 milligram, then you have to give 500 milligram subsequently. So they won't be doing well with 100 milligram. Next time you give the bigger dose.
There are some Fc gamma receptor polymorphisms have been indicated in rituximab response. I'm not sure if anyone is looking into that. That will be a better way of actually dosing rituximab.
People look more into the antibodies rather than the Fc polymorphisms, more with eculizumab rather than with rituximab.
Yeah, no, certainly I think the antibodies to rituximab have never proven to be actually clinically significant in terms of their ability to reduce or cause depletion of the B-cell. In ANCA vasculitis, certainly Fc gamma receptors were studied in the context of rituximab response. Perhaps that's something to do.
Agree.
so there are some nuances to it. So the practical purpose is that every patient, of course, you need to decide whether it is difficult to treat, decide the dose, decide the monitoring time, and then decide about redosing. And as has been very well said by the panelists, that a protocol in your own mind, maybe you can put it down when you start, so that your journey with rituximab is not. So there was some just a thought at half-life of the drug in different disorders. So if you see in case of ANCA vasculitis about 23 days, in membranous because it is gone down to it is a shorter one. In children it can be longer if it is sensitive. In rheumatoid arthritis it is given. So rituximab may remain depending upon if it is lost in the urine or not and what indication there is. So I already asked some of these questions and we move on to. So there is some suggestion, at least in the minimal change group, where what should the KDIGO at 2021 had suggested the glucocorticoids, and then if no use protein use cyclophosphamide also, and then move on to Ritux. But there is some suggestion that one can move to glucocorticoids and then Ritux over cyclophosphamide. At least this is the adult suggestion, and this comes from people who are again brainstorming whether Ritux can be promoted or not. So I think we need to again think whenever you're using a second line therapy to go with the standard cyclophosphamide or to go before that or not, or before the CNI also. Similarly, in FSGS, of course, it remains that the suggestion is CNI, then Ritux, and all of them are nearly at the same level. But in steroid-resistant case, again, there is some recent suggestion that CNI or Ritux, which one to go first. Because sometimes what happens in therapies is that the way it is used is the way it is developed. So because development was with steroids, with cyclophosphamide, CNI, and this, so we also use it the same way. But if you go back and look at the pathophysiological mechanisms, whether we need to alter that order or not, and this is true not only for glomerular diseases but all other diseases like heart failure and everything. Should the drug be used in a series of its development, or is it? So just a thought to see if we can use the next one. And coming to membranous nephropathy, we had a very good discussion in the morning, and there was an equal suggestion that both cyclophosphamide and Ritux. So in your practice, if they're not in a trial, then which one do you choose as the first line therapy?
So we could take the most favorable situation and unfavorable situation. This is with respect to rituximab. It's a panel discussion on rituximab. So the most favorable situation would be somebody who is young, not completed the families. There, I wouldn't think about giving cyclophosphamide because it does affect the fertility. Two is somebody who's having a low titer of antibodies. Low titer is less than 150. Not that it doesn't work in more than 150, but there are concerns about that. So this is the best scenario. The others would be like if somebody with a rapidly progressive renal failure, although it's extremely rare in membranous nephropathy, or somebody with kidney dysfunction, and people with very high titers of antibody, 500, 600, 1000s. So there I would have concerns about using this as an upfront. But not that we do not use that, but yes, like we say, it's not in black and white, it's in shades of grey. Like, some people, they come back with it. You give them corticosteroids for 15 days, they come back with diabetes. You will agree that, it's a very common 20% developed diabetes. So, there you will have to cut the therapy. It's not that you'll put them on insulin and keep giving them steroids. So, this is the best favorable for rituximab, and less favorable for rituximab would be the other.
So, when there is a less favorable thing, do you think about combination or do you go with the Ponticelli?
Then we give Ponticelli. We have not given the hybrid, that is giving cyclophosphamide, rituximab and corticosteroids. We have not done that as an upfront therapy. We used it for relapsing or resistant diseases. Why we have used the hybrid for relapsing and not modified Ponticelli is because of the diabetes. So that is one of the, and sometimes people have these bone issues, osteonecrosis. There you want to give brief steroids. So there we have used this kind of regimen. But if you look into the dose of corticosteroid and cyclophosphamide, the hybrid therapy offers you that, very good remissions. It has all the pluses of cyclophosphamide and corticosteroid and the minuses of the side effects. Like, steroids, the newer hybrid therapy, steroids is used only for 3 weeks. 1 milligram per kg for 1 week, 0.5 milligram for the next week, 0.25 milligram, and stop. With it, they have more than 80% remission rates. I think that is something looking into the future, because OB is not going to be affordable at least for a foreseeable future.
That was the thing that, and this monitoring you mentioned about the monitoring of plateau and also C90. So you monitor at what point your plateau to make sure you want to do the second dose or?
So we do it at the baseline. Baseline could be sometimes, you do a biopsy, you get you do a PLA2R antibody, then you start the treatment. If it is less than a month and a half, we just take that as the baseline. We don't repeat it. But if it is more than 6 weeks, then we repeat the PLA2R. Once the therapy is started, we repeat it at the end of 3 months. 3 months, 6 months, and then 12 months. This is our protocol. But what the evidence says is, you need to keep repeating it every 3 months. Like, till it becomes negative. Like, sometimes it will become negative just with treatment. Sometimes it will never get negative. You will have to have a second line agent. So your objective should be is to get your PLA2R to negative. Because once the PLA2R is negative, your probability of complete remission is higher and also the probability of relapse is lower because partial remission is something which is very uncertain in membranous nephropathy. Like somebody has 3.51 is nephrotic, 3.49 is subnephrotic. So, but for a patient, it doesn't matter much.
So important again is monitoring the plaque war, and a lot of patients find because it costs also. So that's the reason. But I think in the overall cost, I think sometimes it is something of our mind also that we must have to monitor that and then redose. If it is not coming out, you redose.
If at the end of 3 months, if the patient has not achieved remission, which doesn't happen, to be honest with you, 3 months no membranous achieves remission with rituximab, or the PLA2R is positive, which inevitably in most situations would be positive in high titer. So there we redose them with rituximab.
So when do you actually consider this is difficult with Lupus to go? I mean, I would change to another anti-CD20 or go to another thing. What is your trigger that, okay, 6 months, 12 months, 1 year? Or
so the best thing with membranous is like, you don't treat it for some time also, nothing happens. Like, so that's an advantage with membranous nephropathy. Generally, 9 months is the bitter spot or sweet spot, whatever you want to call it. So that is the time where you can take a call. If the antibody is persistent at the end of 9 months, because sometimes you give a shot at 3 months, it takes 6 months for the antibody to dwindle down. So at the end of 9 months, you assess if it is positive at 9 months, then the probability of achieving any further immunological remission is low. So you can plan your second line agent there. Yeah, now you see that you done antibody at 3rd month, it is positive. 6th month, it has become negative. Patient has not achieved remission. At 9 months, you see that the patient is still antibody negative. Then you believe that the patient is at least 3 months antibody negative. Then you could look at the serum albumin trends, because that is what is serum albumin, one of the best markers, not the protein. So if the serum albumin has improved, it has come 3-ish plus it has come. So you can wait for some more time, because membranous is not an issue because AKI doesn't happen with it, and it's a very safe disease.
So you dose them every 6 months later on, or
no? We don't. We take a call at 9 months if they are still persistently nephrotic with PLA2R positive. We start the second line. Inevitably, previously we used to give these cyclophosphamide and corticosteroid, the Monticelli protocol, but now we are moving towards the hybrid therapy, because hybrid therapy, the dose of cyclophosphamide is less, prednisolone is also less, and immunological remission with that is more than 90%. Even in our experience, where this is much worse than the Caucasian. Caucasians, everything is like, other than the IGA, similar to us. Other diseases are like, they have milder disease.
But in membranous, do you think that your CD19 correlates with your plaque coming down and the response on this?
We did do this exercise, but we found that, we have patients whose CD19 is depleted, but they didn't achieve the remission. This is what Gemritex also, this is what they showed, that there is no 1:1 correlation. It's better to put your money on the PLA2R. Like, that's what they think. Cost is same. Like PLA2R and CD19 monitoring, the cost is same. You put your money on PLA2R rather than.
So in a non-PLA2R, as you mentioned in the morning, would be the severe non-responding, non-nil.
Yeah, so it depends upon whether non-PLA2R is PLA2R positive or negative on the tissue. Like if it is positive, then it could be an immunology. It's a different set. And if it is negative, then you treat like what we used to do before, like.
Are there any questions on membranous disease of the lab? If there are any questions on panels, want to have any opinions or? If not, then I'll move to IGA Nephropathy, which Saxena has a lot of experience, and the single trial was there. It was a failed trial. So you want to speculate why you think this reduction not work in IGA, or are there a section of patients where you think there is still some hope, or because we are moving to therapies which affect the B cell, like the ones that atacicept and heparin and those blockers, but direct anti-CD, you think?
Again, more to do with the antibody not being in the circulation than more so in the B cells being in the tissues and in the Bayes patches, the committed B cells which produce galactose deficient IgA1. They mistraffic into the bone marrow and the localized lymphoid tissue rather than having antibody. That might be one of the most logical reason why rituximab is not working. The other thing is plasma cells. It's producing the Gd-IgA1 and CD20 is not there in the plasma cells.
So that's again the thing is that there was a lot of hope, but it didn't work in at least IgA nephropathy. But what's your thought if it were a vasculitis or a Hannock-Schollenberg? Is it more favorable to try with
Yeah, yes, definitely maybe more favorable because it's a systemic vasculitis, and whatever is even if it is Gd-IgA1, there is significant amount of it in the circulation. So, and it's a very mild disease.
So yes, in Hannock-Schollenberg vasculitis, maybe there's a role of rituximab, but right now most evidence suggests that maybe other B-cell therapies will be tried. The next disease which we all have been discussing is about the lupus. In lupus, I'd like to ask Dr. Manan, and what's his thought about the role of rituximab in lupus and how does he use it, or if yes, how and how?
Actually, most of the lupus we are treating without rituximab. So we are giving either our cyclophosphamide regimen or MMF, and it usually works in most of the lupus. It comes, and we use rituximab in some patients who have, apart from renal, non-renal flares and all that. When there is a flare, we can use rituximab in that situation. The second thing is the recurrence of proteinuria. That is something down the lane. Suppose patient is on MMF or something like that, and there's some slight flare down the lane. That is where we can add rituximab to mycophenolate, which does seem to help. So of course the trials with rituximab were not, LUNAR trial was a failure, but the reanalysis of the LUNAR trial showed that those patients, unlike membranous, those patients who had a CD19 response did actually do well. So we can use second line agent. Unfortunately, I have not used it much, so I can't say that maybe one or two patients, that's the only thing I can say.
That's a very important point, and actually I also replied on that. This was the LUNAR trial which was studied with the speed, degree and degree of B-cell depletion. So if you get a good B-cell depletion, actually the patients with a good favorable outcome in the LUNAR trial, and they reanalyze the trial. And therefore, there might be still a segment of patients where they're not, because currently belimumab is unlikely to be available to us for cost and other reasons. So if we fail the first line MMF and cyclophosphamide and steroid, what next to offer? Either to go to CNI, add CNI, or to use. And many patients, CNI is not easy to use in lupus because they already have renal dysfunction and a lot of apprehensions to use that. So in that situation, maybe there are situations where more B-cell depletion may be useful, and taking it from the other therapies for lupus which are upcoming, that is the daratumab and also the CAR T-cell therapy, where if you achieve good B-cell depletion, then probably the disease might come under control.
No, just didn't want to say. I agree with that. And CAR T-cell study was 100%.
100%. So maybe that the dose, sufficient dose or not. There is some thinking that in lupus, maybe whenever there is increase in IgG, the effect of lupus is less. There is polyclonal gamma globulinemia, and because there is some interference with the FcN receptors and other things. And also that there is more BAFF and APRIL in these patients. So maybe you require a higher dose, or maybe to see some patients or who would respond to that. That's the only thing. If there are any more questions on lupus.
The other thing is that this rheumatologists use a lot of rituximab in lupus or non-renal indications. But I think we have very good results with our regimen of cyclophosphamide MMF. If you are treating it properly, one of the old concepts is that lupus is a disease of remissions and relapses. It's not that. It should be a disease of continuous remission. You should maintain the patient in remission. Each relapse associated with significant renal loss. So we should try to prevent relapse at all costs, and that is the only way is to keep them on a regular. MMF is a beautiful agent to keep them in remission. So there are patients who fail, and that is where we make it.
Coming to last about the other indications we used is any other indication, like vasculitis, which we discussed, and he showed us all the ways which are the indications and how to use them. So I thought I would omit those questions. It's already been very well discussed. And other situations like C3GA and all those, so where do you use Utux apart from all these other glomerular diseases?
We don't use it in any C3. We use nephrolate as the primary therapy. We don't use it in recurrences. Yes, we use it in patients who have recurrent FSGS post-transplant. We do use them after plasma because that we reduce the dose of MMF, because post-transplant setting when you use MMF and rituximab, a lot of leukopenia and neutropenia. So we reduce those 2 mg BD of MMF, along with that we use rituximab at baseline, and again we repeat at 3 months because there is probably proteinuria. Other than that, I am not aware of any other situation.
anti-CFH antibody.
Yeah, that I think she's an expert by.
Thank you.
Yeah, that's fine.
So anti-FHR protocols we have usually stayed conservatively with IV cyclophosphamide based protocol. We did a small comparison of patients in which we checked rituximab versus cyclophosphamide, assuming that B cell depletion would result in antibody production, more focused manner, it would be better. It was not better. It was really similar. And there is some concern among complement biologists, which I'm not very clear on that front, about rituximab not being very effective when we were in that meeting. They did say that when a situation of complement activation is present, in that setting, probably cyclophosphamide would be better to use than to use rituximab.
That's right. Yeah, I also read so that when the complements are low, in lupus also the complements are low, rituximab not much so well, because you need complement dependent killing. And maybe there where the obinutuzumab or others might have some better efficacy compared to
the rituximab has been positioned as a drug to be given in young ladies. I've had occasions where ladies have come back with the product information saying that they can't procreate for 1.5 years after taking this molecule. So where does this stand actually?
This is the Roche's. This is the product that's by the Roche. So that's what they say, because they play safe. Even with MMF also they say, even if the males are taking MMF, you should avoid, having a So that's a product information, because even there is one effect, they will go by that. So the general consensus is 3 months of rituximab bit is off. It's an immunoglobulin, 5 half-lives, 23 days, 5 half-lives. It's gone.
So, quick one. Does the rituximab not helping in lupus nephritis? We are forgetting the plasma cell component, which does not obviously express the CD20. And if you look at the antibody titers in these patients that receive rituximab, for example, the anti-pneumococcal titers of IgG, they remain rock steady despite receiving rituximab. So these probably are the plasma cells contributing to the pathogenesis, which probably rituximab is not helping. In such cases, anti-plasma cell therapy may be considered. And that may explain why it may work in some people and why it may not work in other people. So pathogenesis, I think, someone said that immunology is like a football ground where you watch one patient, you win the rest of the match. So I think there are so many escape mechanisms here that you need to
I would add to that, with rituximab in lupus, there is a concern. It's, you need to take your microscope and dissect and get this kind of results. But with obinutuzumab in lupus, the nobility that did show benefit. So although it was just statistically significant. So that's how it is. Probably it's
how much depth you can actually achieve.
Exactly, because in lupus you have all the lymphoreticular organs everywhere, it's active. Whereas in membranous nephropathy, it's not that kind.
So just quickly go through this. We'll discuss some of the side effects, right? So one was the infusion related side effects. Sometimes there's a concern you start rituximab and then patient has chills and rigors. So what do you?
So if you want to honestly ask the patient and get the reaction, it's about 75%. 75% of our patients have some. Obviously, most of them you don't do anything. But if you talk about serious reactions, it's about 10%. But most of them are.
So generally, if there's a mild rigor, you will continue the therapy. And
so, we use pre-medication on all our patients, and I don't think that's such a problem with us. Certainly not, because so it's usually a delayed serum sickness-like reaction happening day 5 to 7. And sometimes you might have urticaria happening day 2. And when we looked at our sequential rituximab patients, we did have a subset of patients, and while you said HACA are usually not clinically significant, there was a bit of an association between human anti-chimeric antibodies and the incidence of delayed kind of reactions as well as lack of B cell depletion. There was a trend to that. So, but reactions, fortunately or whatever, when we use pre-medication, first dose we do hydrocot, second time we use, first time we use hydrocot, Avil and paracetamol, and all the other times we use Avil and paracetamol. and it doesn't really have a issue.
So when I said 70%, it meant that 60% out of them was not informed to the doctors. That means nurse, while recording, she said that, do you feel any chills? Because we have a checklist. So, obviously the patient says that we recording. Only 10%, and we use pre-medications, we use methylprednisolone. We used to use hydrocortisone, we have moved to methylprednisolone. We use about 125 milligrams of methylprednisolone each time. Whenever we use each time, we use it for the first dose. We use it each time. Yeah.
After that, we had a paper yesterday, pre-transplant 200 milligram we are giving. He was also tried 24 hours, since we had after 1 hour.
Happens.
Yeah, I have also seen
that severe bronchospasm and we had anemia here, and we asked them to get a Lupus Nephritis if he completely denied. So I don't want to any other.
So we had a like in this patient, this patient did not agree, and then later on we used podocytopathy in this patient, and remission for some period of time, but then the availability and all that was difficult. So we gave the system over the infusion of 24 hours. So that is when we realized that you can extend the infusion rate very low over 24 hours. And this patient, as soon as we try to even try rate of infusion, that patient
with obinutuzumab, I'll just share an anecdote, though it's slightly deviant. We had a patient who was resistant. We gave obinutuzumab, responded. Then again had a surge in her PLA2R level with proteinuria. So when we gave her the third dose, that was about 1.5 years later, she had a near death. She almost had a vasovagal and was near death. So that can still happen, because these are biologicals. It's difficult to predict. It can happen with.
Take home is that rituximab infusion reactions can happen. Pre-medication is very important, and every dose is important. A lot of people have it with second and third doses. Generally, we dose it in our ICU, we put a bed and then dose it there, so that if there's any problem, we don't have. I never dose it outside the hospital setting. That's the basic thing. And there was one little thing about this late onset neutropenia, and so we have observed a lot of it in transplant. But in other situations also we see quite a bit of it.
We actually have done a formal analysis. In most of our FSGS patients, post-transplant, whomever we have given, all of them developed. That's why I said that we had to go down on. Now, MMF, we just put them on 250 milligram BD because they developed neutropenia. Whereas in the non-transplant setting, we never found. We analyzed actually 100 patients. Actually, it was 0. Then our pathologists refused to do it. Until that, in 100 cases, there have been no instance. So we will not do it.
So generally, yeah, you're right. So we did also the same, probably with the co-administration of other anti-proliferative drugs. That's where we.
Yeah, so the Japanese report a lot of neutropenia, and they almost always give another medication alongside either MMF or CNI going on, and they tend to get more neutropenia than we do. I can understand that it could be the frequency of testing, and these things do matter in Indian setup versus elsewhere. That is also to contribute because, for example, India never reports neutropenia with levamisole, and levamisole is known to cause neutropenia in almost 2 to 8% of kids. And why do we not see it then? Because we don't probably measure ANC often enough. So both things are important. We probably need to look for it, but probably if you're not using concomitant immunosuppression, it's not such an issue.
I think we're nearly coming to about 50 minutes of discussion, and if there are any questions that is bothering you regarding rituximab, you can ask. You can write down one of the questions, or you can even ask the panel. I once again thank for all. Actually what they do into their practice. This is very important to hear from first hand how it is being done. And thanks once again for all your inputs.